Okay, everybody. Can't you can hear me okay?
Yes, I can.
All right. Well, thank you all for joining. I am Rob Allison. I'm an assistant professor here at WVU School of Medicine. I'm also part of our core faculty for our family medicine residency here up in Morgantown. And I had a little part in helping Dr. Unger get our Project Echo started. And when she initially approached me to say, "Hey, can you give an update on eosinophilic esophagitis?" I said, "Oh boy, why is the American College of Gastroenterology updating such a relatively rare disease?" But as I dug into it, I started to realize that maybe it's not as uncommon as we might think. So, see if we can get started here. By the end of this presentation, I hope that you all will be able to explain the clinical, endoscopic, and histologic characteristics involved in eosinophilic esophagitis. I hope you'll then be able to list the four main treatments of EOE, as I'll be calling it, and then lastly, identify some unnecessary testing and treatments that also could be involved with EOE. So, as I previously mentioned, EOE was once thought of as this rare case reportable encounter. And sorry, I just had to start. A case reportable encounter, but now it's commonly encountered in clinical disease scenarios and a major cause of upper gastrointestinal morbidity. And before we really dive into it, I did want to take just a minute and refresh all of ourselves with some terminology when we talk about upper gastrointestinal disease states. So first is dysphagia. And dysphagia is this difficulty swallowing. Specifically, it's that sensation of food or liquid getting stuck or having trouble passing from the mouth to the stomach. Now, that's a little different than gastroesophageal reflux disease because that is the traditional heartburn or sometimes epigastric pain, but we'll talk about that in a minute, but more that chronic reflux like presentation where the gastric contents are coming back up through the esophagus and leading to symptoms, but also to some complications. And lastly is dyspepsia. And that is truly epigastric pain. Now, sometimes we tend to blur the lines with all of these, but just to set the stage, I wanted to really refresh ourselves with these three distinct characteristic uh, points because we'll be kind of using them discriminantly as we talk about EOE. But before we get into EOE, I really started to ask myself, well, what are some of the hallmarks or when did we start to see some of these disease processes, specifically talking about GERD versus eosinophilic esophagitis? So when it comes to gastroesophageal reflux disease, we've known about this for a long time. It's been clinically documented as far back as 1960, but believe it or not, even in some of the earlier literature in the 1890s, people talked about diseases of the stomach, and it's thought that they were referencing GERD. Now, we see this quite often, and it's a prevalence of 13 to 15% in North America, and that was from a study by Fass et al. And we all should feel pretty comfortable seeing GERD because it's quite prevalent in a pretty broad scope family medicine practice. Now, when it comes to eosinophilic esophagitis, this has been diagnosed much more recently. And so in the 1990s, there were two case reports of roughly 10 children apiece. And these children were found to have eosinophils deposited on biopsy taken from the esophagus. From there, those studies were replicated, and we found that there were more eosinophils deposited in adult esophagus, and therefore we started to make the term and the diagnosis eosinophilic esophagitis. But it's much less common in clinical practice. And so as you can see, it's not even 1% of the presentations that we can see in North America. Said a different way, it's roughly about 1 in 3,000 cases that you might see. So if you have a large enough patient panel, you might see it, but it's not going to be coming through your door every day. However, it can make a really big impact if you can identify it and really help to improve this person's quality of life. So who is that patient that walks through your door and you should be thinking about eosinophilic esophagitis? Well, it's a person that probably needs an endoscopy. And why would they need it? Well, 50% of the people that have food boluses and they go to the emergency room because food is stuck in their throat, they have EOE. 1 to 8% of people with refractory reflux or heartburn have EOE. 6% of non-cardiac chest pains. 5% of IgE-mediated food allergies, and 4% of abdominal pains or aerodigestive symptoms all can have EOE. And as I talked about, it is this eosinophilic deposit in the esophageal tissue, and that can lead to stricture. So what is eosinophilic esophagitis? It's a chronic allergen-induced T-cell type 2 immune-mediated disease of the esophagus characterized by symptoms of esophageal dysfunction and eosinophilic predominant infiltrates on the esophagus. A lot of words that we'll break down, much more streamlined as we go. So this is a disease that can present in infancy and can manifest all the way up through adulthood. So when we start to think about infants, they may have poor growth, failure to thrive, feeding intolerance, failure to progress to solid foods, increasing time needing to eat, food refusal, or increasing time to complete meals. All symptoms or ways that this child is trying to prevent that discomfort when they eat. When you think about children, it's a little bit more obvious or mechanical. And so they can have abdominal pain or vomiting. They may have some regurgitation. Heartburn is common in that population. They may have mealtime triggered chest pain. And they may have prompt esophageal regurgitation of swallowed food. So again, it's much more of a mechanical obstruction leading to symptoms. And then that's where we see it in the adult population. So for adults, they really do have this solid food dysphagia. Their food, not as much liquid, but food gets stuck in the esophagus. That leads to food impaction that can feel like chest pain or heartburn. And worst case scenario, if that impaction does stick and they have tremendous time trying to force it down, that can lead to a perforation or Boerhaave syndrome. And so again, kind of looking at this picture, you can see that narrowing in the more distal esophagus, which then leads to their symptoms. So the American College of Gastroenterology came up with this impact score. And these are behaviors to assess for yourself while in the clinic and talking to someone with dysphagia. And the acronym IMPACT stands for imbibing fluids. And that's where they have to drink a lot of fluids to help get each bite down smoothly. They have to modify them, and therefore they cut it into smaller pieces. Prolonged meal time suggests that they eat more slowly, and they are usually the last one at the table. Avoiding hard textured foods like dense meat or crusty bread and foods that stick are often avoided to minimize symptoms. They chew excessively into small bites to allow easier passage. They may turn away medicines. So they may try to avoid taking tablets or capsules because those often can get stuck in the esophagus as well. So all good things to think about or ask when you have a patient that presents with dysphagia. Now, EOE is also more of an endoscopic evaluation. And when the endoscopist does their upper GI procedure, they're really looking for 5 different things. And it's referred to as the ER-EFS scoring. This is likely not something that most family physicians do, but if you are a family physician who practices endoscopy, this might be something that you want to be familiar with. And so the acronym edema, rings, exudates, furrows, and strictures are all clinical findings that are highly suggestive of eosinophilic esophagitis. And lastly, as we'll see based on the guidelines, when we make a diagnosis of eosinophilic esophagitis, it's lastly a histologic diagnosis. And so the hallmark of histological evaluation is that there should be 15 eosinophils per high-powered field. But as we'll talk about later, it's also mentioned that it's very common to see mast cells, lymphocytes, basal cell hypertrophy, and spongiosis involved in these biopsies. Because as we start to become more and more familiar with EOE, we're learning that although it is eosinophilic predominant, there's lots of other cells that are involved in developing all of those endoscopic findings. So the American College of Gastroenterology in 2025 came out with their eosinophilic esophageal guidelines, and they really broke it down into diagnostic criteria, treatment recommendations, and what options to avoid when we think about EOE. So their very first recommendation was just what we talked about. EOE should be diagnosed based on the presence of esophageal dysfunction or dysphagia. There should be at least 15 eosinophils per high-powered field. And this is one thing that I wanted to highlight. You should be evaluating for non-EOE disorders. And so at the bottom of that slide, you can see all of the other reasons that someone might have dysphagia. And so we talked about GERD originally. That can definitely esophagitis, achalasia, hypersensitivity reactions, autoimmune diseases like Crohn's, Schottky's ring. So it is important to recognize that not all dysphagia is eosinophilic esophagitis, but eosinophilic esophagitis should definitely be on your differential when someone presents with dysphagia or any of those impact symptoms that might suggest or steer you towards considering dysphagia. So when it comes to their second recommendation, they suggested that we use a systematic endoscopic scoring system like that ER-EFS slide that I showed you to characterize the endoscopic findings at every endoscopy. And we'll see where this becomes important, but serial endoscopies are a hallmark of eosinophilic esophagitis. And so the endoscopist should always document what type of visual findings they see in order to help grade the treatment when it comes to pursuing treatment for eosinophilic esophagitis. Thirdly, that the endoscopist should obtain at least 6 biopsies. And these are usually 3 from the upper esophagus and 3 from the lower esophagus. And that's because EOE is a patchy disease and it usually clusters, but it may not be present at all in one biopsy, and it can be very evident in another. The last thing that they mentioned is that targeting EOE findings like those white exudates are always a good idea because those are often pathologic findings of eosinophilic infiltration. Now, the hallmark change from the 2013 guidelines to the 2025 guidelines were that the American College of Gastroenterology eliminated the requirement for PPIs to have been trialed prior to the diagnosis of EOE. Said another way, and because this was very confusing when I first started looking at this, they initially thought that if someone symptomatically got better and had improvement in their eosinophils on biopsy, they would call this a separate term, PPI responsive esophageal eosinophilia. Different than eosinophilic esophagitis, I know. Rather confusing, but if they responded to PPIs and the eosinophils went away, they thought that this was separate and not eosinophilic esophagitis. But now they've taken that away, and we'll talk about treatments here. But one thing I wanted to highlight when we talk about treatment is that as good family doctors, we may want to consider pursuing non-pharmacologic treatments first. And when it comes to a non-pharmacologic approach, it's recommended that we suggest a food elimination diet because it can be very effective when we treat EOE. Now, they give two options. One is this elemental diet. And what that really means is that the patient is purely drinking amino acid formulas. It's really effective, upwards of 90% effective, but it's also really poorly tolerated. Only about 30% of people that tried the amino acid supplementation were able to complete it. It's just because it's really limiting and it really isn't conducive with normal routines. So the second option is more of a food elimination diet. These are also really effective, and the American College of Gastroenterology highlights 6 core allergens that they recommend trying to eliminate. And you can see there at the bottom, animal milk or dairy products, wheat, soy, eggs, nuts and peanuts, and fish and shellfish. So if you consider starting with maybe one of them and see how symptoms go. And if they still have symptoms, then you can progress by suggesting that the patient eliminate a second allergen. And then you can progress all the way up to 6 FED or food elimination diets. And this is just a nice table that they had in their guidelines that outline how this works and what the efficacy is. So at the bottom, you can see that elemental formula is 90% effective, but the 6 FED can get upwards of 70% effective. So that is definitely something to consider if you want to pursue a non-pharmacologic treatment. And if they do get response within about 6 to 8 weeks, then the hallmark of this is that you should reintroduce one allergen at a time to see if symptoms return. And once the symptom returns, then you would go back for endoscopy to see if there are eosinophils again. And that would suggest that that food or that allergen is probably causing a problem. And so therefore, at the bottom of this slide, it's exactly that. Endoscopy with biopsy required after each food, it's each food reintroduction to assess for reoccurrence. And symptoms alone aren't sufficient to determine triggers. So when they write that, they want to suggest that you're really not looking for symptom improvement as the hallmark that the disease is treated, because there often can be eosinophils and evidence on endoscopy, even if the patient isn't having symptoms. So just to reiterate, they do want patients to have an endoscopy after every food is reintroduced. And so that can be very cumbersome on the patient. So a patient might come to you and ask, well, hey, can't I just do allergy testing instead? Isn't that good enough? Can't I figure out what foods I'm allergic to and therefore I'll know what foods to avoid? Unfortunately, that's not the case, because the skin prick test or the patch test That's an IgE-mediated allergy response. And EOE, or eosinophilic esophagitis, is a type 2 immune response with T helper cells. And so the concordance rate is very low. Only about 13% of people that have skin or patch testing will also identify their foods that lead to eosinophilic infiltration on esophageal biopsy. So it is recommended against to do IgE-mediated skin testing for food elimination. So if they say, well, you know what, I've tried my diet and I can't seem to figure it out, and I really don't want to change my diet, so what pills do I have? Well, another recommendation that they made when it comes to treatment is PPIs. And we talked a little bit about that PPI responsive eosinophilic or eosinophilia. And now the American College of Gastroenterology has said, you know what, let's just make it easy. And PPIs are a treatment option for EOE. And that's not because it's suppressing acid, but it's thought that PPIs might have some novel mechanisms to also reduce the eosinophilic infiltration by decreasing eotaxin 3 expression. And that is one of the cell expression signals that pulls in eosinophils to the esophagus. And it's thought that PPIs may have this increased barrier protection for the esophagus. So the food allergens won't and can't penetrate the esophagus to then lead to that type 2 immune response. So this is really important when we think about PPIs because they're much more than just acid suppression. And as we can see here, they do lead to histologic remission in about 50% of patients, which is pretty good when this study kind of looks at all treatments involved. But dosing is important, and it's not our traditional gastroesophageal reflux disease dosing, it's high dose. And so we're talking about kind of double the dose we typically would use for reflux. So 20 milligrams of omeprazole twice a day, or esomeprazole 40 milligrams twice a day. They have found that twice daily dosing is more effective than once daily dosing when we look at histologic resolution or histologic improvement. But again, kind of going back to what's important to the patient is going to wonder, why am I going on a PPI if I don't have heartburn? But it's up to us to encourage them and educate them to say, well, it's not really a heartburn issue that you have going on. It is this immune-mediated allergen response, and PPIs can help decrease the eosinophils and some of the structural changes that we can see, even though you may not be having symptoms. So a second medication that's out there for EOE are the swallowed topical steroid class. And these have a really strong recommendation. These are a kind of a hallmark of EOE. And it's because every swallowed topical steroid trial has demonstrated a significant histologic impact with response rates of 60 to 70%, so better than PPIs. And it's really important that we counsel patients to take these after meals because we don't want the food and or the drink to wash away these topical steroids, because the whole point of swallowed topical steroids are for the medicine to sit on the esophagus and work directly at the site of action rather than being ingested. So they did split or talk a little bit separately about the two different types of drugs that are considered topical steroids. And that's a separate recommendation. And they did look at the efficacy between fluticasone and budesonide. And it turns out that both treatments are just as effective. Budesonide had about a 71% improvement histologically, and fluticasone had a 64% improvement. And those were statistically insignificant. And so either one is an option. The trouble here is that only budesonide as this oral suspension is approved by the FDA. And it comes in 2 milligram twice a day for adults and 1 milligram twice a day for kids. Well, then what's that mean for fluticasone? Well, interestingly, you would have to use an asthma meter dose inhaler or some type of inhalant, but this is where you're not inhaling it, but you're swallowing. And that gets really tricky, especially because they recommend 1,700 plus micrograms in divided doses. And sometimes those meter dose inhalers only get 100 to 500 micrograms at most. So people are doing a lot of puffs swallowed twice a day, which can get pretty tricky. So I think when you're looking at this, it might be worth pursuing the FDA oral budesonide suspension rather than that off-label fluticasone MPI. And so people will ask all the time, what about the systemic absorption and what's the risk of adrenal insufficiency or osteoporosis? And unless they are also taking concomitant high-dose oral steroids, inhaled steroids, and or oral prednisone or cortisone, the risk of adrenal insufficiency and osteoporosis is pretty low. The big risk is oral candidiasis. And so about 25% of patients on swallowed topical steroids are likely to get oral candidiasis. So that is something that you should really be aware of and ask your patients about. So the last medication class are the monoclonal antibodies, and specifically dupilumab. And that is the one drug that they have suggested for treatment both of children as early as 1 year old, but can go all the way up through adulthood. And these are specific to people that are non-responders to PPI therapy. So when you're talking about adults or any child greater than 40 kilograms, it's 30 milligrams sub-Q once a week. And they have pretty good histologic remission, again, 60% here, kind of in line with PPIs and topical steroids. And interestingly, young children have a better response rate. Theirs is weight-based, and they do an every other day dosing. And they're at 68% histological response rate at 16 weeks. So also really effective. So somebody might ask, well, what about the other monoclonal antibodies? And so they did this recommendation or guideline did look at several other monoclonal antibodies listed on the screen there. And brenzulazumab, mepolizumab, and reslizumab are all IL-5 agents and therefore should decrease the eosinophil count because IL-5 is related to increasing eosinophils. And it did. It led to dramatic reductions in histologic findings on biopsy. The problem was there were no endoscopic or symptomatic improvements in the study group. So although they limited and almost eliminated the eosinophilic infiltration, patients still had symptoms. And that highly suggests and supports that a lot of those other cells, the mast cells, and some of that other cellular change that we noted previously are truly part of the structure of these endoscopic findings and likely need to be targeted a little bit more with future research, but just targeting eosinophils is not effective at symptomatic or endoscopic improvement. One that does have some promise is cendakimab, and that targets IL-13. And that we know plays a role in eosinophilic esophagitis. And the phase 2 trial saw a significant improvement in eosinophilic count, histologic improvement, and symptomatic improvement. And it's currently in phase 3 trials, but they just didn't have enough phase 3 data to suggest or support this medication right now. So that's why it's an indeterminate recommendation. And lastly, when it comes to monoclonal antibodies, omazulab is not recommended for treating EOE. That medicine, again, specifically targets IgE. And as we've mentioned, EOE is not an IgE-mediated allergic response or immune response. EOE is that type 2 immune T helper cell immune response. And so omazulab really targets asthma or atopic disease and doesn't do anything for eosinophilic esophagitis. So then someone might say, well, if we're talking about mast cells, what about cromolyn and montelukast? And although they do treat and help with mast cell stabilization and leukotriene receptor antagonists, these medications were not shown to be any more effective than placebo when treating EOE. So there's a recommendation to not use cromolyn or montelukast when treating EOE. So lastly, some suggestions when it comes to EOE is that the continuation of effective dietary and pharmacologic therapy for EOE should be continued indefinitely because of the high risk of reoccurrence, both of symptoms, I should say, with symptoms, histologic inflammation, and endoscopic abnormalities. EOE is this chronic disease, and there's almost universal reactivation as soon as 90 days for some folks when treatment is stopped. And untreated disease or treatment interruptions can lead to worsening fibrostenotic progression with those rings and furrows in most patients. So as we've seen, eosinophilic esophagitis is a chronic inflammatory and fibrostenotic disease that requires management and monitoring of clinical symptoms, endoscopic findings, and histologic improvement. So some of their last recommendations for surveillance suggest using endoscopic dilation as an adjunct to medical therapy for treating the esophageal strictures or fibrostenotic lesions causing dysphagia in EOE. But dilation shouldn't be the only treatment, because again, this is an inflammatory disease. And so we want to use those anti-inflammatory treatment methods to help the underlying symptoms and histologic changes, and not just dilate the esophagus, because that dilation will often come back without treating the underlying pathology. One note that they made was that radiographic imaging, like esophagograms, can be really helpful, because there are several cases reported where the endoscopy did not see a narrowing, and the esophagram did show some stricture or narrowing. And so if there is a concomitant esophagram, that can really help, especially in kids, as we'll see in the next few slides. When we talk about response to treatment, we're really talking about symptomatic, endoscopic, and histologic outcomes, because it's really important to remember it's not solely based on symptoms. It's the other two as well, because symptoms really only correlate modestly with biologic activity. So what does that mean for patients? Well, it really means that they're doing a lot of endoscopies. And so they are usually going to go for an endoscopy about 8 to 12 weeks after oral therapy, and about 12 to 24 weeks after the initiation of monoclonal antibody therapy. And we talked about with the dietary advancements, every time they advance their diet, they're going for another endoscopy as well. So it is a very laborious diagnosis for the patient. And the goal is to achieve that histologic response of less than 15 eosinophils per high. Remember that eosinophil counts should be quantified based on the biopsy from every endoscopy. And that's because you really want to know, did they have 30 eosinophils and we got down to 20? Is that major, or did they have 200 eosinophils and our treatment got them down to 20? That's a much bigger decrease in eosinophils. And so it's nice to know from a treatment perspective how that treatment is going, engage anti-inflammatory effect. And monitoring for other histologic features, as we talked about, that basal zone hyperplasia and lamina-propria fibrosis, can also help, and I suspect will be playing a bigger role in the guidelines in the years to come, because we know that there are other cell-mediated changes that we might not have been able to target just yet when it comes to treating EOE. When it does come to children, it's recommended to suggest an esophagram for evaluation of fibrostenotic disease. And this is really because children probably are going to have a harder time with endoscopy. The fear that may come with the procedure, the sedation, the unnecessary procedure itself. And so it's recommended that these children undergo esophagram to find a lesion if present before dilation. Now, again, we need the endoscopy for biopsy, so that is a problem with this whole concept because the three-pronged approach requires biopsy. But now there are even there are diagnostic modalities that might eventually, not yet in these guidelines, replace biopsy. And there are nasolaryngoscopy where they're pushing a small sponge down through the nose and into the esophagus, and the sponge is trying to collect cells. And they also have a pill probe that they administer similarly, and that probe is meant to try to collect some inflammatory cells and biomarkers to try and eliminate the need for biopsy. Now, both of the sponge and the pill are not in prime time yet, but they are coming and specifically geared towards children to eliminate the need for endoscopy. And lastly, evaluation by a feeding therapist or dietitian as an adjunctive therapeutic intervention for children with EOE is very, very important. And that's because we want to ensure that they have adequate growth, that we promote normal development, and that we encourage proper nutrition for these young children as they get older with this chronic disease. So hopefully that was a crash course in the clinical endoscopic and histologic characteristics of eosinophilic esophagitis. And by now, hopefully you can list those 4 main treatments for EOE and identify some of the unnecessary testing, like patch testing, and some of the treatments that aren't recommended for EOE. Before we get to our case, I'm happy to field any questions.